Okay, hello everyone. Can you hear me?
Yes, Professor.
Thank you very much. Okay, so I would like to start the presentation. So today's lecture will be in two parts. So the first part, I will discuss about the PSMA Theranostics and indeed more dedicated to the prostate cancer management. And the next part, I would like to introduce Dr. Qaid. Dr. Qaid was our international fellow in Seoul National University and now working in Brazil. So he will review us about prostate cancer imaging at the next part. Okay, so today's contents will have four parts. So the first, I will review some general management of prostate cancer. And I'd like to introduce the second part as a current advance in PSMA diagnostics. And thirdly, the considerations for PSMA therapy. And lastly, I would like to introduce some ongoing clinical trials. So the prostate cancer is the second most common cancer globally among men. And although incidence and mortality rates are vary greatly between countries, its incidence and mortality are increasing. So these are some disease continuum of prostate cancer. And starting from the localized disease, it can advance into a biochemical failure, and then it can be divided into like metastatic hormone-sensitive prostate cancer or non-metastatic castrate-resistant prostate cancer. And then it finally can move on to the metastatic castration-resistant prostate cancer, which needs like additional systemic therapies. And after that, it can also move on to what might be the later stage is the treatment refractory metastatic castration-resistant prostate cancers. So this is some well-known continuum of the prostate cancer. So before moving on to what kind of managements are in the prostate cancer, we need to stratify the risk to find to select what might be the initial treatment for the patient. And the risk stratifications are according to these factors like TNM staging, Glycine grade group, PSA level, and percentage of positive biopsies or other germline testing. So so firstly, I just like to introduce about the Glycine score is used by pathologists to grade prostate cancers. And if the cancer cells and their growth patterns look very abnormal, a grade 5 is assigned, and the Glycine score is the sum of the two most prevalent patterns, primary and secondary patterns. So for example, if the Glycine score is written as 3 + 4, and it means that most of the tumor is grade 3, and the second most common or most malignant grade is 4. And regarding to the Glycine score, in 2014, the International Society of Urology Pathology had suggested to make a grade group using this Glycine scores here. So, and you may easily understand that although the Glycine score is 7, the 3 + 4 and 4 + 3 is different. So according to these Glycine score group and stages and PSA level and like T stages, this NCC and risk group have stratified the risk of the patient. So this is some summary of risk stratification and choice of initial treatment for localized prostate cancer. So in the first, like very low and low groups, the treatment for an individual patient depends on a informed patient decision. So it is based on the patient's decision what to do. And the basic choices are like, it can be observation or active surveillance or external beam radiation with or without brachytherapy, and brachytherapy alone, or radical prostatectomy can be an option for the treatment. However, in the patient with clinically localized or intermediate or higher risk patients, the prostate cancer can have more extensive tumor in these groups. So actually in these groups, the imaging for metastasis can be considered, and especially for a very high risk group, probability of lymph node involvement is high. So like in these very high risk patients, you should actually do the imaging of the pelvis or pelvis MRI and CTs. And also in these patients, doing the PSMA PET imaging can be considered to know whether this is really a localized disease or whether there is an advanced or a metastasis by the PET imaging. So then, if there is, like from the PSMA imaging or CT or MRI or other imaging agents, if we see a metastasis, or if there is a biochemical recurrence or locally advanced cancer after the initial therapy, there needs a systemic therapy. And the most well-known systemic therapy is the androgen deprivation therapy in this stage. So the critical roles of androgens in stimulating the prostate cancer growth was actually established in 2041 by Charles Huggins. So these two papers are some initial papers that indicate the role of androgens. So these findings actually led to the development of the androgen deprivation therapy as a treatment for patients with advanced prostate cancer. And the figure shows the hypothalamic pituitary gonadal axis and targets for androgen deprivation therapy. However, usually these all four targets are targeting the hormones, but what we usually call the androgen deprivation therapies are these two, like GnRH agonist or orchiectomy. So, and these CYP17 inhibitors or androgen receptor antagonists are known to be like second line agents, which are indicated in the after the androgen ADT or with the ADT. And this androgen deprivation therapy is, although it is a palliative treatment, it can actually normalize the serum PSA levels in about more than over 90% of patients. And it can produce objective tumor response in 80 to 90%. And this anti-tumor activity of this androgen deprivation therapy also can improve the quality of life, and because by reducing the bone pains. And however, the problem is that this androgen deprivation strategy currently seems to incompletely suppress the androgen levels. And so the androgen receptor mediated effects at the tissue level, which is left over, and it may cause some resistance to this androgen deprivation therapy. So once more, it is not clear what is the exact mechanism of the resistance. However, this figure is some summary of how the this resistance comes. So the central part of the resistance is known to be that it is due to a continued androgen receptor signaling. And there are some parts, as you can see from the image, like first mechanism is that tumor or some tissue can actually make their own steroidal hormones, which itself might lead to persistent tissue level androgen dysfunction, although there is a castration. And also there can be a mutation in the androgen receptors, which can allow like other alternative ligands. And thirdly, there can be some mutation and the androgen receptor can be amplified. So there will be a exaggerated receptor signalings. And there are other not ligand dependent, but ligand independent factors also, such as coactivators or co-repressors or other also stem cells can have an effect. So these actually can induce these continued androgen receptor signaling can make a castration resistance. So now we have to deal with this castration resistant prostate cancer. And before moving on to how to treat this CRPC patient, we need to know what is the definition of the castration resistance. So the actual, the definition may be the patient should have a castration and the castrate levels of serum testosterone should be below 50 nanogram per deciliter. And there should be a evidence of disease progression while the patients are under the androgen deprivation therapy. However, there are no widely accepted criteria to define the progression while the ADT. The only evidence of disease progression is an increase in the serum PSA, but different criteria and different guidelines suggest different like doubling time of PSA or the exact definite PSA levels. So it is not actually, there is no widely accepted criteria, but different criteria. But generally, what we see as a disease progression is firstly PSA elevation or new metastasis or progression of existing metastasis imaging. So here also the PSMA PET imaging can be considered to see new metastasis or progression of the disease. And next part is then we need to divide the CRPC. There are two categories, which is the metastatic CRPC, and the next is non-metastatic CRPC, which refers just only the PSA rise without any demonstrable radiographic findings. So why we differ these two is that the therapeutic approach can differ in these two patient groups. So now I would like to show what are some options for the CRPC, systemic treatment applied for a CRPC patient. So the first option is generally it is applied to continue the androgen deprivation therapy. Although it might have a less effect in the tumor control, it can have a effect in the slowing down the progression, or it can have a release in the symptomatics. So generally, it is suggested to continue the ADT. However, there should be a addition of the drugs. And some well-knowns are, firstly, the interference with androgen stimulation. And what we have seen earlier are these two parts. So the first will be the androgen receptor antagonist, which are known to be enzalutamide, apalutamide, or darolutamide. And the CYP17 inhibitor can be known as abiraterone. And there are also chemotherapies like docetaxel and cabazitaxel. And also there are approved immunotherapies like pembrolizumab, and also PARP inhibitors can be applied. And finally, the well-known for us is the radium-223 can be applied in this CRPC patient. So for details, I would like to show like this enzalutamide is to be known as a product name is Xtandi, is an orally administered agent that act at multiple sites in the androgen receptor signaling pathway. And so it has been shown to improve the overall survival in both situations, like after the docetaxel chemotherapy or before the docetaxel chemotherapy compared with the placebo. So from these results, the enzalutamide has been incorporated in the treatment of the men with metastatic CRPC. And again, this enzalutamide or this androgen interference subjects like apalutamide or darolutamide has shown its efficacy in a placebo-controlled randomized trials in the patient with a non-metastatic CRPC. So these three drugs are also not only for the metastatic CRPC, but can be used in a situation of now non-metastatic CRPC patients. Next is about the abiraterone, which is the CYP17 inhibitor, and it blocks the synthesis, and the product name is Zytiga, and it blocks the synthesis of the androgens in the tumor as well as in the testis and adrenal gland. So what it can do is it can actually block the tumor steroid, the steroid hormone production in the tumor or in the tissue level, which is already known, which I have discussed as a reason for the resistance. So it can actually overcome this resistance mechanism. However, one thing to know is that this abiraterone also decreases cortisol. So when you use this abiraterone, it should be used together with the corticosteroid. And there has been a trials for the abiraterone too, and it has shown a improvement in the overall survival for both, like after therapy, after chemotherapy and before chemotherapy. And so it has also been incorporated for the metastatic CRPC patient therapy. And next is about the chemotherapeutic agents like docetaxel and cabazitaxel. And these taxane groups are the only cytotoxic chemotherapy agents that have shown a significant prolonged overall survival in the prostate cancer, the metastatic prostate CRPC patient. So these have been approved, and generally, and this cytotoxic chemotherapy is generally reserved for men with relatively rapidly progressing symptomatic disease. And generally, because of the cost and some issue cost, so docetaxels are preferred over cabazitaxel as the initial chemotherapy regimen. But the cabazitaxels may be preferred in older or frail patients and those at high risk for neutropenia, because this cabazitaxel has relatively lower toxicities. However, it is known that the efficacy of the both chemotherapeutic agents have no significant difference. And there are other options like targeted therapies known, immunotherapies and PARP inhibitors. And since the pembrolizumab has been approved by the FDA to be used for a variety of advanced solid tumors, which has a deficient mismatch repair or high levels of microsatellite instability. So in the prostate cancer, which has such a finding, also it can be, this immunotherapy can be applied. And for men with a metastatic prostate cancer who have like germline or somatic DNA repair mutation, PARP inhibitor can be an option. And lastly, radium-223 is a ARPA emitting radiopharmaceutical. And because it has a high energy but relatively short distance, so it has a it is believed to have better efficacy with rather low bone marrow toxicities. So it has, from this randomized clinical trial, it has shown that this radium-223 was well tolerated and increased both overall survival and time to first symptomatic skeletal-related event to happen. However, this radium-223 is limited only to a symptomatic bone metastasis without evidence of visceral metastasis. So this is some summary of how the flow chart for how you deal and how to treat the metastatic or non-metastatic CRPC patient. There are still some controversies which may be better. Like there, as you have seen, there are many choices of systematic drugs for the CRPC patient. However, exact comparison between those drugs are not done in a large group. So what might be the better option can be revealed from later studies. Okay, now I would like to share more recent trend in the systemic treatment of how these are applied. So the first trial I would like to show is the Titan trial. This is a phase 3 study about apalutamide versus placebo in patients with the metastatic castration-sensitive prostate cancer, not resistance. So this trial wants to see the efficacy of apalutamide in the earlier phase in the castration-sensitive patients. So it has shown a survival benefit of apalutamide over just a standard androgen deprivation therapy alone for these HSPC patients. And another study is this ARCHES. I'm not sure for the naming is right, but this also has a similar approach to see the efficacy of the enzalutamide in the metastatic HSPC sensitive patient. And this study also showed a survival benefit of enzalutamide over the ADT. So, and the next trial is about a STAMPEDE named as a systemic therapy in advancing or metastatic prostate cancer evaluation of drug efficacy. And this is a randomized open label multi-arm trial to actually provide evidence as to what is the best way of treating men with newly diagnosed advanced prostate cancer. So as you can see, there are diverse multi-arm and diverse comparison of systemic drugs have been done from this trial. So for the summary of recent trend in the systemic treatment is that, as you can see, not only for the metastatic CRPC patient, but these trials are now seeking the efficacy of the systemic treatment in more earlier phase, like metastatic hormone naive prostate cancers or non-metastatic CRPCs, or in the localized disease at like very early stage. So the trend is that these systemic treatments are done earlier. However, what kind of dilemma may come out is then, if these treatments are done earlier, and then what if the patient have a progression after all these therapies? At this later stage, there is lack of options left. So for the summary of the first part of the general management of the prostate cancer, the risk stratification is firstly the important for the treatment selection. And for the advanced and MCRPC patients, there are treatment options as a continuing the ADT and like some drugs that interferes the androgenic stimulations and chemotherapeutic agents such as docetaxel or cabazitaxel. Or there are also targeted therapies like immunotherapies and PARP inhibitors, and also our therapeutic agent, the radium, is available for the MCRPC patient. However, there are recent trend of drug trials that are wanting to see that these systemic treatments can be done earlier. However, as discussed, there is a dilemma. If these systemic drugs are done earlier, there is no option left at the later stage. And as you can see that these like pembrolizumab or immunotherapies are only limited to the patient who have such a mismatch repair deficiency or like status of MSI high, and like this PARP inhibitors can only be applied to the patient who have DNA repair gene mutations. And also radium-223, although effective, can also only be indicated for a systemic symptomatic bone metastasis patient and not indicated for visceral metastasis. So like later stage patient has a very limited options left. So there is a need for other options, and so that will be the PSMA therapeutic agents. So now I would like to review about some recent advance in this PSMA therapeutic agents. So firstly, the prostate-specific membrane antigen, now you will be very familiar to this, is a type 2 membrane protein. And it has a diverse functions like signal transductions and neurotransmitter interactions and receptor functions. And the beauty of this PSMA is that it is like highly expressed in the, especially in the cancer cell lines compared to other like normal prostate cells. And so it can be used for both imaging and therapy. So firstly, what has been done was to see whether this PSMA can be imaged or targeted. So I think this might be the first study about using the concept of using PSMA as a target, and have shown a relative effect that this PSMA positive tumor can be well seen through the imaging. And the next agent was published, has been reported in 2011, and it was the well-known, the Gallium PSMA 11 agent. And it, from this basic study that had moved on to the first in human imaging in 2011 May. So this Gallium-68 PSMA 11 is now the most widely used PSMA agent. So from this first in human study, there has been many prospective and retrospective and also clinical trials. So this gallium PSMA 11 has been the first PSMA, first FDA approved PSMA targeting PET imaging agent for the prostate cancer now, and now it can be available in the clinical situation. And there are also following agents like F18 labeled PSMA agents. And I think these regarding this imaging agent will be discussed in the following session by Dr. Qaid. So with the advent of this imaging agents, there has been also incomings of that this target can be used as a not only the imaging, but also a therapeutic target. And to best of the knowledge, this the first that matched this concept of theranostic was first published in 2015 by the German groups. And the name was the lutetium-177 PSMA INT, and which means like for imaging, and INT imaging and therapy. And this radiomatter-based PSMA ligand was successfully applied for therapy of mCRPCs according to the paired imaging agents. So using the concept of theranostics, and as you can see from the study, it have shown in the in vivo studies that gallium-68 PSMA INT and lutetium PSMA INT have a very similar biodistribution and also has a identical physical chemical properties. So now you can use this PSMA agent to actually stratify the patient and now deliver the lutetium PSMA INT for the therapy of the patient. So as you can see, the study further showed that it can have a therapeutic effect when after the stratification by the imaging. So now people have seen that this PSMA theranostic can be effective in this CRPC, like prostate cancer patient. So shortly after this report, there has been many other drugs coming out. And the most widely studied agent until now is the PSMA 617. And also the German group firstly shared their experience of 30 patients who have done by the compassionate use of this lutetium PSMA 617 therapy. And from the result, it have shown that 21 of 30 patients had a PSA response. And in 13 patients, it was also more than percent of decrease was shown. And after like 3 cycles, 8 of 11 patients achieved a sustained PSA response for over 24 weeks. And from the study, normally the acute hematotoxicity was mild, and xerostomia or nausea and fatigue occurred sporadically, like in 10% of patients. And so from the study, it concluded that this lutetium PSMA 617 can be a promising dual therapeutic agent for mCRPC. From here, many retrospective and prospective studies regarding this PSMA 617 have been published, and the Australian group have conducted a phase 2 clinical trial. And as you can see, the eligibility criteria of the study was that it should be pathologically confirmed MCRPC, and it should have a progressive disease after the standard treatment, and it should have a high PSMA expression. And the level of how to define the high PSMA expression was whether if the tumor environment, SUV max of the tumor environment was higher than 1.5 times of liver SUVs. And there are like many other inclusion and exclusion criteria, but some interesting point of this study was also that it have included the exclusion criteria where if there is a discordant lesion, like from the FDG PET and PSMA expression, if there is a discordancy, this patient should be excluded from the therapy. So from these criteria, 30 patients were enrolled in the study and have done the lutetium PSMA therapies. And again, what was firstly the interesting point was that they actually made a exclusion criteria using some discordant regions from the FDG. And this actually came adapted from the experience with the PRRT and the neuroendocrine tumors. So like in patients with who have FDG, high avidity of FDG, and with a low or absent SSTR expression, these patients have relatively aggressive characteristics of disease, and which actually cannot be effectively treated with a targeted radionuclide therapies. So like, as you can see, like in this patient, there is some, although there is a high PSMA uptake along the bone region, there are some discordancy in the liver lesions or in the liver or in the lymph node of the SCN lymph node. So like these kind of, if there is such a discordancy, this patient is also not excluded or excluded from this study. And from the study, 17 of 30 patients achieved a PSA decline of more than 50% or more, and objective response in the nodal or visceral disease was reported to be more than 80%. And from the study, the most common toxic effects were grade 1 dry mouth, recorded in 26, which is 87% of patients. And like more higher adverse events were mostly shown by the myelosuppression, like hematologic toxicities were shown as the most common grade 3 or 4 adverse events. And the thrombocytopenia attributed for the most, which is like in the 13% of the patients, which might be possibly attributed by the lutetium PSMA. So it can be concluded that this lutetium PSMA therapy has high response rate and relatively low toxic effects. And including this phase 2 clinical trial, there has been accumulation of studies regarding the PSMA therapy recently. So the study group actually gathered all the articles and have done a systematic review and meta-analysis of these articles to see a compiling and outlining efficacy and safety data of the lutetium PSMA. So in here, the meta-analysis, 17 articles were chosen, and from total of 744 patients were reviewed in the studies. And all the patients included in the studies were metastatic CRPC patients, because in most retrospective or prospective clinical trials until this moment was done in the settings of patient were done in mostly in the compassionate use for the patient with mCRPC who have done a lot of standard treatment, including ADT or like chemotherapies, and who have progressed after these therapies. So these are some summary of the articles reviewed in this meta-analysis. And as you can see, mostly the studies used the PSMA 617, and secondly, the PSMA INT were used. So, and the result of the systematic review and this meta-analysis suggested that the lutetium PSMA therapy can be an effective treatment. As you can see, it had a like 50% of PSA decline in more than 46% of patients. And there has been an objective response in 37%, more than 37% of patients. And you can see a median mean overall survival of 30.7 months and progression-free survival of 11 months. And it also has a low toxicity profile, like only the most common, the adverse event, which has a high, like grade 3 or 4, were related with the hematotoxicity. And in this meta-analysis, the hemoglobin decrease was the most prevalent toxicities. However, overall, there was a relatively low toxicity profile. So these combined results suggested that there is a need for a randomized controlled trial actually to assess the further efficacy of the lutetium PSMA therapy in mCRPC patients. So recently, it has been reported the randomized clinical trial, phase 3 clinical trial, which is named as the Vision trial. So this is a phase 3 clinical trial, and the eligibility criteria is, as you can see, and it says like international study. And mCRPC patients are the eligibility criteria, and the patient should have a progress after previous treatment, which includes the androgen receptor pathway inhibitors and 1 or 2 taxane regimens. So it is not like or, it should have both. So it is like the patient characteristics are mCRPC, and it should have at least 2 treatments before lutetium PSMA. And it also should have a high PSMA expression, and the definition of high PSMA is which is higher than the liver. And as you can compare with the earlier article from the Australian group, this the criteria is relatively liberal, and so it can actually have more patients included in the therapy. And it also should have no PSMA negative metastatic lesions in like known bone or soft tissue metastasis, which is like lesions which is bigger than 1 centimeter, and lymph node which is bigger than 2.5 centimeters, and solid organs. So, and the study was done comparing the patient who have gone the standard of care compared to the lutetium PSMA plus standard of care. And it was randomized to 2-to-1. And the primary endpoint was to see the PSF, the radiologic PFS and the overall survival. And like it also have shown a secondary endpoint like ORR or disease control rates. So this is the summary of the study enrollment. And as you can see, from 1,179 assessed patients, 1,003 patients underwent PSMA 11. And as you can see, quite a lot of patients survived and was included as showing a positive PSMA expression in the PSMA PET. So, and lastly, the 831 patients underwent the randomization. And one thing to be known is that because of the high dropout in the standard of care arm, there was an intervention in 2019, March. So from that moment, and there was also in that moment a radiologic PFS was added as an alternative endpoint. So imaging for the response was done in these groups. So the overall survival was actually evaluated in total of 831 patients, but the radiologic PFS was evaluated in 581 patients. So this is the result. And so from the median follow-up of 20.9 months, the PSMA 617 plus the standard of care showed a prolonged progression-free survival with a 5.3 month gain, and also a overall survival of gain of 4 months. And for the progression, there was a reduction in 60% of reduction of progression and also 30% of reduction in the survival. So it have shown a efficacy. And for the secondary endpoint, it also have shown that the objective response was significantly higher, like 51% had CR or PR by the PSMA 617. And also the first symptomatic skeletal event was significantly reduced when applying this PSMA therapies. And for the toxicity adverse event, the incidence of adverse events of grade 3 or above was actually significantly higher in the lutetium PSMA group, and the prevalent was in the thrombocytopenia and anemia, which is very relevant to the previous meta-analysis or previous studies that these hematologic toxicities are most common, grade 3 or 4 adverse events. And the most general adverse events were fatigue which was followed by the dry mouth. And one thing is that although there was a higher number of adverse events in this intervention group, the thing you should know is that also because of the longer progression-free survival and also the overall survival, the treatment exposure was significantly longer in this standard care group. So from this study, as a result, so in the lutetium PSMA is now you can see as a effective and relatively safe therapeutic option for the advanced PSMA positive metastatic castration resistant prostate cancer, and now which is now waiting for the approval. So in summary, like we can see the lutetium PSMA therapy was applicable in the patient with the mCRPC, and the adverse events were relatively low, but the hematologic toxicity were the most common grade 3 or 4 adverse events. And the most common adverse events were the fatigue and dry mouth. Okay, so I think this is the, we will have some break, and I think we can move on to the next part about considerations of PSMA therapeutics 10 minutes later. And before having a break, if you have any questions or comments, you can ask freely. Do you have any questions or comments? Or you can just put out a chat if you have. And in before the, like at the break time or in between the lectures, I will appreciate if you can fill out the questionnaires, and there is a link in the chat. If you can open the chat there, you can see a link, and you can just freely comment us about this lecture series, and we can actually we can choose some subjects that you would like to review, and we would like to introduce some more other experts from like Korea or from international experts for this lecture series. Okay, I think there is one question about what is opinion about PSMA treatment in mCRPC with estimated survival less than 6 months, such as 3 to 4 months. Actually, I would say I could not give you a best answer for this question. Actually, I think like urologists or oncologists might have more opinion about this part. So, but I think it might be, it should be considered case by case regarding the patient characteristics. So these lutetium PSMA therapy, although has a very toxicity regarding the hematotoxic toxicities. And in the advanced group who have very limited like survival, like less than, as you mentioned, like less than like 3 to 4 months, usually have a depressed myelosuppression are combined in these patients. Because mostly these patients have very disseminated bone metastasis and bone marrow involvement of the prostate cancer. So these patients may not be eligible for the lutetium PSMA therapy, and the PSMA therapy may evoke more of these hematologic myelosuppression, and which can be some more risk than the gain for these patients. But for others, like if there is like bone marrow, the bone marrow is within a normal range, this lutetium PSMA therapy, although might not increase the survival, but it also can improve the symptoms. So if the symptom is not controlled in the patient, for the purpose of some symptom relief, the PSMA treatment can be considered. However, as I told in the first part, I think because of the myelosuppression, these patients might not be indicatable for the lutetium PSMA therapy. Okay, And if there is not another question, we will have a 10-minute break. And let's see again 10 minutes later. Okay, thank you. Okay, I think it's time. So I would proceed on for the next part. So what I would like to discuss at the next part is about consideration, like practical considerations in doing the PSMA therapy. One thing to say before is that I don't have a much experience in the PSMA therapy, so it might be quite limited in not a deep aspects. So please remind that. And so like there are some parts of consideration, firstly, how to select patient selection. So who will benefit from this therapy? And next will be about like before administration of the therapeutic agent, the quality control should be discussed and done. And we need to deal about treatment protocols, like how to administer in what kind of speed, and also post-therapy imaging should be considered. And there also should be a consideration about treatment schedule. Normally we do like 6-week interval and 4 cycles, or some trials and maximum to 6 cycles. It should be considered for patients. And also, like, what should we do after the finalizing the therapy? Like, how shall we do the follow-up? Or if after the therapy, what if there is a progression after this the lutetium PSMA therapy? Is there a chance for a retreatment, like salvage therapy should be considered? And one more thing I did not put in this part is about the response evaluation. Actually, the response evaluation is very important for this prostate lutetium PSMA therapies. And I think this might be discussed with Dr. Qaid in the next session. Okay, so for first, who shall we treat? So simply, the beauty of theranostics is that there is a pair diagnostic image, like for gallium-68 PSMA 11 can be a pair image of gallium-68 617. So it has a pair image, so it can actually detect who will benefit from the treatment by the image. However, as you can see, some studies that have been reviewed here, that like different selection criteria are used to define the PSMA high expression or PSMA expression. Like it can be higher than the liver, or it can be 1.5 of the SUV max of the liver, or it can be a like more complicated, like SUV max more than 20 at a site of disease, and SUV max more than 10 at site of measurable disease. So applying these different criteria, there are some patients who can be included or excluded from the therapy. So there is no clear conclusion what is the optimal cutoff for the PSMA. So, but there is some way, logical way is to actually see the tumor dose response and correlation with the pre-treatment uptake. So firstly, what you can do is you can see the tumor dose response firstly. And then you need to define what is a effective threshold dose to have a treatment response. And then what you need to see is what is the SU pretreatment uptake that will end up as a mean dose in that tumor. So for instance, like here, like 12 or 11 mean dose to 12 gray to tumor might be some threshold that have a effect in the tumors. Then you can find like what might be the SUV mean that will match the 12 gray to the tumor. So this kind of approach can be logical. And however, there is also concern that not only the uptake itself is a relevant factor. Actually, from this like 2017 paper, it have shown that these tumor uptake, which was referred as SUV max of bones or ratio from the liver or spleen. However, these were not significant to predict the therapeutic effect. However, there are some factors that these patients were not, these were performed in 40 patient hormone refractory patients. So there should be more data, but what we can know is that not only the tumor uptake is relevant to the therapeutic effect, there will be other predictors like the age or Glycine score can be another factor. So there has been a more large data report. So this group actually suggested a nomogram to predict outcomes of lutetium PSMA therapy in MCRPC patient using a multicentral retrospective data. So what they have done was they retrospectively screen the data like 414 patients. And finally, 270 patients were enrolled and assigned to the cohort. So what was done was they divided the patient into a development cohort and also a validation cohort. And from here, what they have found was what they wanted to find was what are the predictors of overall survival and progression-free survival. And another part was 50% decline of PSA from the baseline. So for instance, this is a predictor which was found from the overall survival. So number of metastasis and tumor SUV mean and like number of the nodal metastasis or whether there is an involvement of liver metastasis were some relevant factors found out from the multiple logistic regression. And using this logistic regression and Tox regression models and lasso penalty for variable selection, they have made using this predictors generate a nomogram. So what they have generated was, so from these predictors, they have generated a nomogram. And so this is the nomogram they have generated. And how it works is that you can firstly check for like what is the time since the diagnosis and whether the chemotherapy status was done or not done, or you can just check the hemoglobin status and tumor SUV mean. And what you can do is you can see the points at the upper part. And then what you can do is you can sum up all the points from each predictors. And if you sum up, you can get a like total points. And in this total point, what you get is like overall survival probabilities. So from this nomogram, what they have seen was this was well matching with the predicted survival and also observed was quite well matching. And this nomogram was validated in both the development cohort and validation cohort. So internal validation also showed was good, and also external validation showed a good consistency. So, and when they divided from the development group as like high risk and low risk group, it was also similarly applied, could be applied to the validation cohort. So this nomogram now is available as a website here, under here. So if you go in, you can just put like time since diagnosis and like medical history and laboratory values, and you can check some PSMA PET-CT parameters. And with this parameters, if you calculate, what you can get is the data of like what is the overall survival predicted, probable overall survival of the patient, or probable PSA progression-free survival of the patient, and also the probability of PSA response. So from these, from the result, you can actually you can use these data for considerations whether the patient should undergo the lutetium PSMA therapy or not. But more importantly, the selection of the patient should be done in the multidisciplinary team approach, since this is the prostate cancer patients is not only a patient, he had like diverse course of medical treatment or surgery. So you should have some concern and discussions with the urologist and like medical oncologist when selecting the best candidate for the PSMA therapy. However, you can get help from these nomograms suggested from the studies. And next part is about the quality control. I think this might have been previewed from the previous workshop, and you might have seen the image. And this is the pre-therapy gallium-68 DOTATO PET. And what you can see in the next slide is a post-therapy lutetium scan. But what you see is a significantly different distribution of the agent. And normally the DOTATO have shown like mostly a hepatic metastasis. However, the lutetium DOTATO scan shows a very diffuse uptake along the skeleton, like axial skeleton and appendicular bones. And at the same day, there was another patient, patient number 2, had a also had like enormous hepatic metastasis. So this patient had a first post-therapy. However, at the second post-therapy, this is the same day as this therapy. And as you can see, there was also like diffuse skeletal uptake, which is significantly different from the first therapy. So then you can imagine what's the therapy, is it really the lutetium DOTATO? So then what do you have to check is some like checking point. And actually this patient had a pancytopenia as a result. So what you need to check is like whether this is a really well radio labeled. So normally what we use in here are like company made, like from, for instance, Lutatheras are made in Novartis, and it is given by flight into Korea. However, there might be some sites which import a lutetium and then mix them up and radio label with a DOTATO or PSMA in their site. So in this case, quality control should be done in the site of the production or labeling site. And this is the radio TLC result of the lutetium DOTATO, which was produced in this date. And they have seen that there was a single peak, which has a very high purity. And so it was applied to the patient. However, what you need also to see is that this was the TLC peak, TLC radiotherapy result from the previous treatments. So as you can see, there is a significant difference in the position of this. Although there is a single like peak, there you need to see what was the buffer used for this radiotherapy, and also you need to have an expert to interpret such a result and do a quality control. So mostly what you need to do is you need to see visually whether there is no like artifacts inside or there is a change in colors. And the next part is to check this radiotherapy result and like whether is it really a labeled component should be checked. And in the radiotherapy report, there also should be a buffer. What kind of buffer was used should be actually commented in the radiotherapy result. So there is some issues especially if you do the radio labeling on site. And for the treatment protocol, usually you can do, in Korea, actually, we can do this lutetium-based therapy as a outpatient-based setting. But like there are like different national registration regulations. So you need to follow the radiation protection regulation for each country. And so it can be done both in inpatient or it can be done at outpatient. And normally the administration protocol are done like in the injection speed of over 2 to 10 minutes, which is quite low, slow speed. And the pre-therapy or hydration or post-therapy IV hydration can be done. But we only do like pre-therapy or hydration. And in some patients, corticosteroid and antiemetic can be used. And ice pack can be applied occasionally. But there is a controversy about the real effect to whether it can really preserve the salivary uptake of the PSMA agent. But if you apply, it can be applied 30 minutes before the treatment, and it can be applied up to 4 hours after the treatment. And in our hospital, what we use for the administration is actually the pump. So we use a syringe pump instead of using the gravity method, which is suggested in the Lutathera. So what we seen is that when we use a gravity method, there was some problem of the remnant activity. And also because there is a remnant activity and some malfunctions are coming, there is more chance the doctor should do it by themselves. Then there is a risk of radiation from doing that. So we are now using a syringe pump, and this, as we have seen, there was a remnant activity was minimized when using such a method. And for the post-therapy imaging, you need to think about the purpose of the imaging. So for the monitoring adequacy and whether you want to see the presence of targetable PSMA expressing lesions, just one time point imaging might be enough. But the best might be 24 to 48 hours, because then the background activity will be pretty gone. However, 4 hours in our experience from the lutetium dotatate can also give similar the results compared to 24-hour, 48 hours. So for the patient convenience, like that can be also considered. And for the dosimetry proposed, but like multi-time points are actually required. And for an effective dosimetry, you need at least 3 time points. And like the 3 time points can be firstly the effective half-life, and 3 times effective half-life, and 5 times effective half-life. And however, there are attempts to actually reduce these time points. So there are actually attempts to do like 1 time point imaging for the dosimetry, and like machine learning or logistic regression models and modeling are used to find out like whether it is possible. And you need to think what kind of imaging method you need to use. It should be considered under the availability. Like if you have both the planar scan and the SPECT-CT, you can do like for the patient convenience, and the hybrid method seem to be widely used, and it is done like multiple time points by planar image to generate a time activity curve in the planar image. And to get a more accurate activity, you can use the SPECT at like 24 hours or 48 hours with the planar. So this hybrid method are widely used, but you can do like multi-time point SPECT-CT images, but it actually needs more imaging times. And next thing to be considered is that for the treatment schedule. And as a matter of fact, actually there is no standardized treatment protocol. And as you can see, all these articles, which was reviewed in the meta-analysis reviewed previously, as you can see, the like cycles of therapy or intervals between the therapy differs. And like it can have like 6 to 12 week interval. And the activity also differs from like 1.1 to 9.3 gigabecquerel per cycle. So like these articles have different cycle activities. But the Vision trial, as the phase 3 trial, used a 7.4 gigabecquerel as a fixed dose, which is 200 millicurie. And it was administered every 6 weeks for 4 cycles. But for after 4 cycles, if the patient had a evidence of response in the this 4 cycles, and if there is a residual disease with the PSMA uptake, and if the patient is tolerable, 2 additional cycles can be done. So in the Vision trial, it suggests that it should be given as a 200 millicurie in every 6 weeks and maximum of 6 cycles. So if it is approved by this protocol, then when people buy this lutetium PSMA 617 from Novartis and use it in your sites, you might need to follow the protocol of this. However, there are some still, as I shown you here, there are some controversies about what is the optimal time point of the therapy. So like some studies have shown that it can be, if it is given in more shorter interval, it may have more better theranostic effect. Like for instance, because it is from the concept idea that compared to the neuroendocrine tumors, prostate cancer have relative, like especially the MCRPC patients have normally more progressive disease, and it has more fast progress. So like earlier, to shorten the interval between the cycles can be suggested. And in this group, they said it may have more effect. And what they have found was the median of the progression-free survival was small, but although the patients are not that much, the median overall survival was relatively longer, like from 17 months compared to, although it cannot be actually compared with other trials, it had relatively long median overall survival. And also when applying this, they have shown a low incidence of adverse events, only 2 of grade 3 leukocytopenia and 1 patient with grade 3 anemia. So still, there is a controversy what kind of treatment protocol you should apply for the patient. And I believe it should be considered based on the patient characteristics and like PSA doubling time of progression time of the patient can be considered to decide the interval of the therapy. However, since from the Vision trial, normally the sites can use normally the sites will use a protocol like following this trial. Okay, and the last part for the consideration is about the salvage therapy. So after the therapy, like normally, as you have seen, the lutetium PSMA therapies are given to the patient at the end, like refractory mCRPC patient. So after this lutetium PSMA therapy, there are like no other options to do in this patient. So we can consider to give retreatment of the lutetium PSMA. Then how shall we do this retreatment? And is there evidence of the retreatment? So there are some studies regarding from the lutetium dotatate actually, and it actually suggests some studies suggest that the salvage therapy of lutetium dotatate can be done if there is a progression of disease after a period, which is in like 6 to 12 months after the end of the therapy, and if the disease was controlled in this period. And it should have a reasonable response at the initial therapy, and there should be a adequate tracer uptake at the moment for the salvage therapy. And if these are met, 2 or 4 cycles of retreatment can have a benefit of like increasing the overall survival and progression-free survival. So there has been some very not that much study regarding the retreatment. However, this haven't directly introduced what was the interval between the end of treatment and the start of re-challenge. But the interval was in the paper, it showed that it was like 2 to 24 months for this 30 patients. And as you can see that after this 30 patients from the retreatment had a gain of 20 months survival. And but quite like quarter of patients showed a hematologic toxicity, like near 23%. So like this retreatment can be effective, but you should also consider about the toxicity when you apply the retreatment. And still there are lack of reports regarding this salvage therapy. And there is another part. So if we do this PSMA therapy, as we have reviewed, that the most abundant adverse events are fatigue and dry mouth. So there has been like preventive measures and supportive measures, what to do before the therapy and what can be done after the therapy. Still, there are controversials whether these are really effective to the patients or not, but still, you can try such a measures before or after applying the lutetium PSMA. And also, there another concern is about the bone marrow toxicity. Since it is the most abundant grade 3 or 4 adverse event, we should know what are the predictors of this bone marrow toxicities. And some known factors are from the studies are to be bone marrow dose of the lutetium PSMA, and if there is a baseline cytopenia, and if the patient have high bone tumor burden or previous taxane-based chemotherapy can be a risk factors. And actually, these two may be relevant to the baseline cytopenias because these two tumor burden or previous chemotherapy will end up as a baseline cytopenias. However, normally it is known that these grade 3 or 4 adverse events are reversible after like 8 months of follow-up. But in severe cases, CSF, GCSF or transfusion might be needed for these patients. But the concern is actually that the lutetium is not readily available. Like, we should get it from other sites. In Korea, actually, we get the Lutathera from the Europe. So we need to order the Lutathera like 2 weeks earlier. But we don't know how the patient, the bone marrow function will change after the therapy. So what we do actually is, so for like, if the patient have baseline cytopenias or risk factors, we do very early post-therapy laboratory exams. But actually, in general, we do 4-week post-therapy laboratory exams. But for these risk factor patients, we have like early exam and 4-week, again, 4-week exam. And if there is no decline or abnormality, in some general patient, we can order the Lutathera. However, if there is a abnormality in 4 weeks, we should do another follow-up at 6 weeks to see whether there is an increase or whether it have been gone up to the normal level. And then we can actually order. Thinking about, since the interval between the therapy is 8 weeks, so like 6 weeks is some limit for the ordering of Lutathera. So these are some practical concerns for the lutetium-based therapies. And if the laboratory exams are abnormal at 6 weeks, we actually delay the treatment. And another actually problem is that diffuse bone marrow progression is the most common pattern of the treatment failure. So at the end of the refractory phase of this MCRPC patient, the most prevalent characters are these patients with diffuse bone marrow infiltrations. So it can be hard to differentiate from whether this cytopenias are from the adverse event of the lutetium drug or from the disease progression. So differentiating it is important. Okay, so for the summary, so patient selection, there are diverse factors, but some nomograms are suggested, so you can get help from that. But most importantly, you should do a multidisciplinary team approach. And for the quality control if you are labeling on site, there need an expert to do a quality control. And for the treatment protocol in our institute, we use an injection pump, and which can be effective for minimizing the leftovers or the radiation protections. And treatment schedule is still controversial, and there are debates, but the Vision trial have done 6 weeks and the maximum of 6 cycles. And salvage therapy can be effective according to the lutetium dotatate data, but there is still limited data according to the PSMA therapies. And for the last part, I would like to show some ongoing clinical trials regarding the PSMAs. So now, as you can see from the Vision trial, lutetium PSMA has been placed in this part, like after additional therapy of mCRPC. If there is a progression, you can consider the lutetium PSMA. However, there are needs to broaden the indication. Actually, it is related to broadening the market and broadening our nuclear medicine field. So there is an attempt to actually more get this PSMA earlier. And this one study is actually finished and reported is therapy trial, which is the phase 2 clinical trial. And it is a comparison with the PSMA 617 versus the chemotherapeutic agent. So this have shown that it compared to the cabazitaxel, and before that, the inclusion criteria was the patient who have undergone docetaxel as a previous therapy and who are suitable for the cabazitaxel. In this circumstance, it showed that compared to the cabazitaxels, the lutetium PSMA had a better efficacy of like better PSA reduction, better PFS, objective response, and actually lower adverse events, which are indicating that this can be a effective treatment if there is a compared to the cabazitaxel when there is a progression after docetaxel therapy. And secondly, another study, this clinical trial is ongoing clinical trial, and what the target is to place this PSMA therapy in this part at the starting point of the mCRPC treatment. So it is a comparison of mCRPC in the mCRPC patient, comparing the lutetium PSMA versus like androgen receptor target therapies. So it must have received one prior approved androgen receptor therapies from like in the non-metastatic CRPC conditions or metastatic hormone naive prostate cancer conditions. And it also had PSMA positive on gallium PSMA 11. So here, whether it can be effective was tried. And as you can see, and it will be come out from this trial. And this FLASH trial also are targeting the same placement of lutetium PSMA in this part. And there are another trial is this PSMA addition. This is international multi-arm trial. So it is comparison of in the patient with minimally untreated or minimally treated hormone sensitive prostate cancer. So the target is to place the PSMA therapy here, more earlier patients. And it is comparison with the standard of care like ADT or androgen receptor therapies. And also there is another ongoing clinical trial, which name is Bullseye, is like targeting the oligometastatic hormone sensitive, also again, prostate cancer patient compared with the ADT therapy. And this inclusion criteria are this patient have like no prior hormonal or chemotherapy agent. So this actually is putting more earlier, like here. So this is some summary of like the attempt to actually broaden the indication of lutetium PSMA therapy in the more earlier circumstances. And there are also trials that are trying to do a other attempts, like firstly, combination with other drugs. So there are like a combination with enzalutamide or like PARP inhibitors or immunotherapies are ongoing clinical trials. And there are also another like ongoing trial. Actually, this is funded by the Novartis and it's a phase 1 trial trying to see the efficacy of not lutetium, but actinium, the alpha therapy targeting the PSMA. So actinium PSMA also have shown a very effect in like some limited patient which had no effect in the lutetium PSMA therapies. So it has some shown some efficacy in those groups of who have failed to the lutetium PSMA therapies. So there is an ongoing phase 1 trial. And in Korea, there are some. And I think there are more like PSMA targeting agents made up. But in our institute, we are having an ongoing clinical trial named lutetium DIGU. And it is supported by the Salvage, which is a radiopharmaceutical company in Korea. And so we are now conducting a phase 1 and 2 clinical trial to see the safety, tolerability, and dosimetry. And lastly, for the phase 2 trial, the PSA response of this lutetium 177 DIGU in the mCRPC patients. So briefly, this angle and like this GUR compound was developed by Professor Jaemin Jung in our institute. And it has been shown a efficacy of targeting the PSMA positive tumors. And this DOTA-GUR and DOTA-DIGU, lutetium DIGUs are actually pair components. So using this, firstly, angle GUR compound, we have done comparison study with the PSMA-11, widely used imaging agent. And from here, what we have seen was the lesion detection and lesion uptake was similar to compared with the PSMA-11. However, normal organ distribution, normal organ uptake was relatively low compared to the PSMA-11. And it was in part maybe due to some higher excretion rate of this angle compound through this GUR compound through the urinary bladder. So for the imaging agent, it can be there can be some limitations because of a high bladder uptake for visualizing the lesions near to the bladder might have some limitations. However, considering as a therapeutic agent, because it has a similar lesion uptake, but relatively low normal organ uptake, so it may have like similar therapeutic effect in the same time have lower toxicity to the normal organ. So in this concept, we gone more to see whether this lutetium-based GUR compound has a therapeutic effect. So we are ongoing, this is an ongoing trial, and we are on phase 1 and 2, and the eligibility criteria are the progressed mCRPC after at least 1 ARDT or chemotherapy, which has a PSMA positive on gallium-68, the G-rate compound angle. So we are going to see the PSA response more than 50% as a primary endpoint. And the treatment protocols are, actually there is a two, at the phase 1, we will decide the dose for the phase 2 clinical trial, but we expect it to be near like 200 millicurie, and we are giving it as a 6-week interval and 4 cycles. And dosimetry will be done at phase 1 trial, and we are applying a hybrid method. So SPECT-CT just 1 time and 4 times of planar imaging for the time activity curve. So this is some image, first patient image, and as you can see we stratify the patient according to the angle PSMA imaging, and you can see that lutetium deagle and angle has a very similar distribution, and it also showed a high uptake in the tumors. So we expect a effective treatment result. Okay, so this is the summary of the ongoing clinical trials that I have reviewed. And so from these trials, we might not only apply this lutetium PSMA at the end stage, like refractory CRPC patient, but also in more earlier phase of the patient. And actually, there are more upcomings that the combination therapy might be more effective in these settings. And also, actinium-based therapy can be a following drug for the treatment of MCRPC. Okay, thank you very much. And so this is the end of my presentation. So do you have any questions or comments? If you have, please freely give us some questions at the chat or by your mic, I think. I think there is a question about a MCRPC patient of ECOG 3 to 4. And I think the answer might be similar to the previous about like life expectancy, like less than 3 or 4 months. So I think these patients usually have a is combined with very low or myelodepression, so it should be. So that might be, and as you have seen, this cytopenia before the therapy is a risk factor for making a adverse events after the therapy. So it should be carefully done. I think also in like this ECOG 3 to 4 patients too. But still, yeah, I think it should be actually considered case by case. And would there be other questions or comments? So if there are, as I also have a lack of experience in this PSMA therapies, I think if someone who have like more experience could, it might be great to, if you can share us about like what should be like practical considerations for in the PSMA therapy. Or okay, I think there are no more questions. So thank you very much. And we will have some break. And I think Dr. Qaid will give us a lecture regarding the gallium PSMA imaging. And before, we have put a chat link about the questionnaires. So please, if you have time, fill out the questionnaires or give us some comments for the next subject of the next like lecture series or workshop, and we can like more improve our lecture series. So let's meet 10 minutes later, and thank you very much. Kai, are you ready?
Yes.
Okay. Yeah. Okay. Thank you, everyone. I think it's time. So I would like to introduce Dr. Qaid. Dr. Qaid has been worked as an international fellow in our Seoul National University Hospital, and he had finished his master's degree in Seoul National University. So he was dedicated as a oncologic imaging specialist here. And now he is in Jules Institute, Jules Bodat Institute, and he also is now experting in the gallium PSMA imaging and prostate cancer imaging. So I think today he will deliver us a lecture regarding the gallium PSMA imaging. So please welcome Dr. Qaid.
Can you see my slides?
I think it's not, yeah. We can see.
It's okay?
Yeah.
Hello, everyone. Good afternoon for you and good morning for me because the different time. I think many of you already know me and other already have been known, known me from Minsak So. Thank you, Professor So, and thank you, Deng Soli, for inviting me to present today about PSMA imaging and prostate cancer, the current progress. And this is what I am going to introduce about PSMA imaging. We will talk about introduction, PSMA imaging for metastasis detection at the time of staging for initial staging and at the time of recurrence for biochemical recurrence, and also PSMA imaging for response assessments and the role of PSMA imaging in peptide radioligand therapy. These are the last statistics regarding the prostate cancer. As we can see in 2020, there was a difference moving of prostate cancer. It is now the second cancer after the lung cancer around the globe, with 1,400,000 cases a year. And also it is the number 5 in the number of deaths regarding cancers in male, with 325,000 per year. However, in Europe, it remains the first one. The prostate cancer actually has a staging system according to the American Joint Cancer Committee, and it follows like every cancer regarding TNM stagings, with this staging from Tx into T4, and they have their own specific systems in risk stratifications using the ISO grades and Glycine Score. The Glycine Score was the old one, but now they are using the ISO group for stratifying the risk. Grade 1, which include the Glycine Score 6, and grade 2 and 3, which include Glycine Score 7, and number 7 is either 3+4 or 4+3. This is in the histopathology of the prostate gland. High risk and very high risk usually grouped as one risk group. Prostate cancer have different presentations in clinical practice, which range from indolent into aggressive. At the beginning, it can be clinically localized disease. However, there are many options of treatment in every stage for prostate cancer. For example, in localized disease, it can be treated by surgery or external beam radiation therapy, or either by androgen deprivation therapy, or it can be under active surveillance. Then the patient stay under treatments until he get recurrence, what we call it non-metastatic biochemical recurrence, or PSA increasing. And in this stage also, it can be treated either by salvage radiotherapy or androgen deprivation therapy. Then the cancer progress into either metastatic castration sensitive or non-metastatic castration resistant prostate cancer. However, also at the same time, there are many options for both kind of treatments. Then the disease also move into metastatic castration resistant prostate cancer. And in this stage, there is either first line or second line. There are many options of treatments. Both treatments can be used as first line, like abiraterone and enzalutamide and docetaxel. These agents can be used as first line or the second line as well. Then the disease become refractory resistance. And however, in metastatic castration-resistant prostate cancer, nowadays we have in the nuclear medicine community introduced the radionuclide therapy, which has been introduced after the low PSMA trial and therapy trial from Australia and the recent Vertion trial. The disease, however, also progress because it is incurable disease. It progress into refractory metastatic castration-resistant prostate cancer. In this stage, it is under clinical trial with many options. And in this stage also, actinium can be introduced. And our topic about PSMA imaging. So we like to introduce a brief introduction about the PSMA as introduction, the structure of PSMA. This PSMA receptor usually physiologically expressed in prostate tissue, and it has low expression in other tissue, and it is also physiologically expressed in a small bowel, in proximal tubules of the kidney, and in brain and CNS in glial cells. But in brain, we don't see it because it is blocked by the blood-brain barrier. However, in prostate cancer, it is highly expressed, around 10,000 times than normal cells, and expressed in more than 90%. And also it is expressed in neovasculature of some solid tumors. The PSMA composed of 3 parts, internal part and transcell membrane part and extracellular membrane part. The largest one, which is extracellular, is the main target for ligand imaging. And among these tracer imagings, now the most commonly used in practice or in literature, it is the gallium PSMA 11 and gallium PSMA INT and fluorine 18 DC FPYL and fluorine PSMA 1007. And the normal distribution of these radiotracers, the gallium PSMA 11 and fluorine 18 DC FPYL almost acting the similar biodistributions, with normal uptake in the salivary glands and also in the urinary system, in the intestine, and the urinary bladder. However, the advantage of gallium PSMA, it is the mostly used in clinical trials and extensively investigated and used in the theranostic setting. There are limitations in gallium PSMA 11, which is related to the gallium generator, most of them, because the limited activity of production and limited time between injection and scan, and the also high urinary activity. High urinary activity, it limits the detection of the local recurrence at the prostate bed. In case of the fluorine-18 DCFPYL, the advantage of this tracer, it can be produced in high amount and it has a longer half-life. This will allow for easy transportation between centers and hospitals. But the problem of this, it needs a cyclotron and radiosynthesis, which is costly, especially for the developing countries, and not used in theranostic settings yet. But in terms of the fluorine PSMA 1007, the advantage of this tracer, it is excreted by extrahepatic that allow for local detection at the level of prostate bed. But the disadvantage of these tracers, the high activity in the liver can limit the detection of metastasis at the liver sites. Regarding the detection rates for gallium PSMA and fluorine PSMA, they almost performing the same. With the detection in this study from Germany by Afir Oromia on 1,000 patients, the detection rate was 80% in all patients. As we can see here, the detection rate is correlated with the level of PSA, which is ranges from 46 until 96, with the increasing level of PSA from 0.2 until 10. The same for fluorine PSMA. This is an example in 251 patients, also from Germany. And the detection rate in this was 81.3%. The same, it is correlated to the level of PSA, which is ranges from 62% and to 94% in more than 2 nanogram per ml. And the question, which is the radio tracer is the best? In this recent meta-analysis, they tried to investigate which is tracer is the best when we are comparing radio tracer to another, which one to choose, either gallium PSMA 11 or fluorine-18 DCFPYL. In these 12 studies for 1,356 patients, they found there is no clear difference between these radio tracers. So which one is available, you can choose. And the PSMA imaging has been validated or shown to be a superior also for the fluorocholine and fluocyclovine. This is an example in prospective validation of the detection of gallium PSMA, which is compared also to the fluorine fluocyclovine. In total of 635 men, the detection rate was 75, with the positive predictive value as calculated according to the standard reference was 92%, and it is 82% as validated by histopathology. Here we can see also the same, the detection rate was related to the level of PSA, which is increasing with the increasing the level of the PSA from less than 0.5 until more than 5 to reach more than 95%. And this is also a meta-analysis in 645 patients to evaluate the detection rates when we use the fluorine PSMA PET-CT in biochemical recurrence, and the detection rate was 81%, with which is ranged from 21 until 88%. Here, the same, it was related to the PSA value, which is around 50% in patients with the PSA recurrence less than 0.5, and it reached 86% in those patients with more than 0.5. Sorry. In the initial staging, this is a big prospective study published by Australian group by Hoffman, and they included 300 patients comparing the CT and bone as conventional imaging to PSMA PET-CT, and they found that the PSMA PET-CT showing higher accuracy comparing to the conventional imagings, and also it has a greater impact in changing the treatment plan in those patients, with 28% changing plan when we use the PSMA PET-CT comparing to 50% when we use only CT and bone. And also regarding the price, which is more cost effectiveness, and they found that there was a superior cost effectiveness regarding the PSMA PET-CT, which is cost around $1,200 compared to 1,400. In this study, they tried to investigate the validation of the gallium PSMA according to the histopathology, and they found that at the initial staging, mainly in intermediate to high risk, there was 24% sensitivity and 96% specificity, and at the biochemical recurrence, the detection rate was 63 for PSA less than 2, and the positive predictive value was 99%. And in this, the recent study in the European Urology journal about the gallium PSMA sensitivity and specificity, they found that also they are validating that the PSMA detection mainly depends on the level of the PSA. And they stratified the PSA level into less than 0.2, from 2 to 0.5, and 5 to 0.1, and from 1 to 2, and more than 2. And the detection was ranging from 33% until 95% when it is more than 2 nanogram. This study was published in using 37 articles on around 5,000 patients. However, there is a question, which is better? Is it PSMA PET-CT or PET-MRI? In this study, they have shown that PET-MR can detect the same level as PSMA PET-CT, with some advantages when it comes into the local evaluations. The PSMA PET-MR was superior to PSMA PET-CT in detecting the extension of localized disease, and also it can be useful for initial evaluation of histopathological biopsy-proven prostate cancer, and it can help also in directing the biopsy. But regarding the pelvic lymph nodes, they also showed a high agreements regarding the to identify whether these lymph nodes are pathologic or not. And another question, is there any value to add a PSMA when we evaluating the local prostate cancer to the multi-parametric magnetic resonance imagings? In this recent article, work prospective trial from Australia as well in 2021, a total of 300 men were investigated, and those patients with suspected prostate cancer with no prior biopsy or MRI. However, they showed that MRI sensitivity was 83%, and it is has been improved into 97% when combined PSMA and MRI. And also the negative predictive value has been improved from 72 until 91% when combining PSMA and MRI. Nowadays, a recent reporting system has been introduced to report PSMA PET CT and PET MRI. They use what is has been introduced previously by the MI TNM system, or Psmas system, which is introduced previously in 2018, and they classify the regional the tumor either into local tumor, and organ confined tumor, or no organ confined tumor, extracapsular extension or seminal physical invasions, then into T4 tumor invading adjacent structures. The same for in lymph node stagings, either N0 or N1, and also the same for from M0 until M1C. And they use the scoring system using the qualitative evaluations and giving 4 scores, either using the blood-borne reference and the liver. In score 2, they used the parotid glands, and score 3, it is compared to the parotid gland. And also reporting according to the PSMA expression. So they either identify that the lesions into benign lesions, probably benign, or equifocal findings, or either probably prostate cancer. And when it is 5 score, it is definitive evidence of prostate cancer. And when we use this one, it helps to standardize the reporting either at the institute level or at the level of the country. And this also in the future help in when we do the multi-center trials or studies. A recent appropriate use criteria for prostate-specific membrane antigen imaging has been introduced in the CinemaMI before a few weeks ago, and they have created which criteria can PSMA imaging is appropriate, and they have agreed that PSMA is recommended for newly diagnosed unfavorable intermediate high risk or very high risk, and also in diagnosed unfavorable intermediate high risk or very high risk with negative equifocal or oligometastatic disease on conventional imaging. And also they agreed that it is appropriate for PSA persistence or PSA rise after undetectable level after radical prostatectomy, and also in PSA rise after nadir after definitive radiotherapy. However, these 4 criteria has been now approved and integrated in the NCCN guideline to be used in daily clinical practice. And the next questions, what is the role of PSMA imaging for response assessments? There is few literature in this area regarding the role of PSMA imaging for response assessments. For example, in this study from the same center where I am now. They evaluated the PSMA changes after introducing enzalutamide and abiraterone, and they defined the responders when they achieve complete disappearance of all lesions on the baseline or decrease the intensity or the volume of the lesions which is visualized on the baseline. And this has been evaluated visually. And the PSMA non-responders either appearance of new lesions or increase the volume or stable disease. And they find finally it was perfectly concordant with the PSA response at the median evaluation of 3 months. And this is study what I presented this year in SNMMI. I performed a study, analyzed 37 patients who treated with taxane chemotherapy, and we evaluated the PSMA expressions using the quantification method, the segmentation method of SUV more than or equal 3, and we measured the SUV max and SUV mean and PSMA TV and TL PSMA, total lesion PSMA. And finally, we classified the patients, identified the response in patients into either PSMA bit responders or PSMA bit non-responders. In the responder patients, either to be a complete response with disappearance of all lesions as presented in patient A, or partial response with decreased PSMA TV tumor volume by more than or equal 30% as shown in patient B. And PSMA bit non-responders, which is shown, which is be either progressive disease with appearance of 2 new lesions or increasing the PSMA TV by more than 30 as shown in patient C, or a stable disease with PSMA tumor volume not significantly changed or the change was less than 30%. And we investigated the concordance with the PSA response, and we find there was a high concordance with the PSA response, and it was 100% in the metastatic hormone-sensitive prostate cancers and 85% in the metastatic castration-resistant prostate cancer. However, we find that this is also correlated to the patient's survival. There was a significant difference between those patients who showed a decrease or response on PSMA PET comparing to those patients who is showing either progression or no response on the PSMA PET CT. In those patients with PSMA response, there was 100% 12 months OS, comparing to the half, around 52% to 12 months OS. And in 2020, there was an assessment criteria has been introduced by the European nuclear medicine, European radiologist, and European oncologist in urology. And they introduced these consensus statements on PSMA response criteria in prostate cancer for PSMA imaging. And the patients has been imaged, and it should go either if there is uptake or there is lesions, we can go with response assessments. But if there is no PSMA uptake at the baseline, we cannot evaluate the response after administration of therapy. However, not all patients, they recommend not all patients to take into response assessments. There is when the clinician or oncologist planning to change the clinical management, either yes or no. If no, no need to do response assessments. But if yes, response assessment is useful. And they classified the patients into responders and non-responders They classify the complete response, partial response, and a stable disease as responders against progressive disease. Progressive disease, which is also new, more than 2 new lesions, and or increase uptake of PSMA by more than 30%. However, the progressive disease has two kind definitions in either polymetastatic prostate cancer or early recurrent prostate cancer. In polymetastatic castration-resistant polymetastatic prostate cancer, there is two methods or two findings, either more than 2 new lesions or increased PSMA TV. When there is increased the PSMA uptake, this definitely progression. But when there is 2 new lesions in polymetastatic prostate cancer, they recommend that to also measure the uptake, either PSMA TV or SUV. And if there is 30% change, yes or no. If there is no change, it remains stable disease. But if there is increase, this is definitely progression. However, it's not the case in early recurrent prostate cancer. In early recurrent prostate cancer, they recommend that any new lesion that is highly suspicious is definitely progression. However, this is criteria is not validated yet. In a previous report before this, there was what we call B3B or PSMA progression, PSMA PET progression criteria, and they define what does the meaning of progression when we see PSMA PET CT, and they recommend either 2 or more new PSMA positive lesions. This appearance in of 2 new lesions and the follow-up PSMA, or 1 new lesion, but this one should be consistent with clinical or laboratory, and laboratory can include PSA, LDH, NSE, alkaline phosphatase, in addition to the clinical status of the patients, if only 1 new lesions, and it should be within 3 months of PSMA, and no new lesions but size increase, and this is evaluated by the uptake, but this also needs to be associated with clinical or laboratory findings and correlative imaging within 3 months of PSMA. This criteria has been investigated in a prospective single-arm trial. They're evaluating the fluorine-18 DC-FPYL or PSMA PET-CT in patients receiving abiraterone enzalutamide. And they found that when they use either delta PSMA, delta percentage SUV max, or delta absolute SUV max, both of them can use to recognize the responders, the progressive and non-progressive diseases. And there was a significant difference in terms of the survival when we use any kind of these uptakes. In those patients who are progressing in the blue color against those patients with no progression. And also, there was a difference in the time until the starting of the new therapy or the time to change the therapy between both patients who are showing progression using this 3B criteria and when using the both parameters, either delta percentile CV max or delta absolute CV max. This also criteria has been investigated in the lutetium PSMA radioligand therapy, and the same they achieved very well. And they, for example, they classify the patients into category A, category B, and category C. Category A, more than or equal to new metastasis. This was defined definitive progression. Category B, new metastasis and any increase in the laboratory factors like PSA, LDH, alkaline phosphatase, or NSA. And category C, distant increase of the tumor volume and increase any laboratory factors more than 25%. However, there was a significant difference when using the PSMA, defining the patients into progressive against others, and also when using the progressive again using the PSMA plus PSA non-progression against those showing progression on PSMA with PSA non-progressive. And there was also a significant difference in the survival outcome of the patients. In these images, it shows an examples. For example, in category A, we can see more than new lesions, wide distributed all over the body. And in category C, this is showing an increase in the volume. For example, in this location, we can see in the femur and also in the humerus as an example, but also it can be noticed in the pelvis and in many areas when we investigated in details. And what about the PSMA bit role in guiding therapy? The main interest of PSMA imaging remains in the guiding the selection of patients for lutetium PSMA or actinium PSMA. For example, in this study, which is introduced by the Australian group, which is lutetium PSMA, but this is the extension of the study with the 50 patients. They used the uptake of PSMA with SUV max more than 1.5 times the liver SUV, or the uptake, PSMA uptake 1.5 times liver SUV. In this study, there was the PSA response was 57 in the original study, but it is increasing to 64 in the expanded group. And those patients who showed a response on PSA, they showed also a better survival outcome comparing to those patients with no PSA response. In the RAP trial, when they compared the lutetium versus cabazitaxel in patients with metastatic castration-resistant prostate cancer, they used also in all studies the PSMA FDG mismatch approach. They excluded all patients showing PSMA negative but FDG positive. But when it comes into the PSMA uptake intensity or activity, they select only patients with at least one site with SUV max more than 20, and all other sites should be at least with SUV max of 10 or more. In this study, we can see the lutetium group showing a PSA response in 66% of the patients. In the recent study, Vertion trial, which introduced the lutetium PSMA comparing to the standard of care. But in this study, if PSMA FDG mismatch was not used, but they used the PSMA uptake more than 1.5 times liver SUV, like what used at the initial assessment for lutetium PSMA trial. And in this study, we can see the lutetium in the lutetium PSMA group, the PSA response more than or equal 50% decline has been shown in 46% of the patients. And also the PSMA PET-CT has been introduced recently on the same populations, including those who has been treated prospectively and in multi-center trial, introducing this new nomogram incorporating the PSMA imaging parameters, mainly the SUV mean, and some analysis like number of lesions and bone metastasis and liver metastasis. Other parameters like time since diagnosis, either the patients received chemotherapy or not, and the hemoglobin level was used also in this nomogram. When we apply this nomogram, patients can be classified into low risk or high risk. The cut point is 197 persons. This is an example showing how it is different in the survival outcome. And also, it is different in the PSA progression-free survival between low risk and high risk when we use the same nomogram. But the cutoff difference, the cutoff is slightly different. With in the PSA progression, there is like here number of lesions, but in this nomogram it is mentioning pelvic node metastasis as well. The cutoff one was 178, and this is how it performed for PSA progression-free survival. And finally, what we conclude that PSMA imaging for initial staging can be used for replacement of conventional imagings in intermediate and high risk. This is recently implemented in NCCN guideline, and in biochemical recurrence, it is suitable for PSA persistence and for PSA recurrence. And this is also implemented in guidelines in European and NCCN. And in response assessment, it is in the initial stage, and the preliminary result has been introduced, and it can be used in novel anti-androgen therapy, in toxin therapy assessments, and also in peptide radioligand therapy like lutetium PSMA. And in the theranostic, in the radioligand therapies, it is essential for patient selections and has the potential for response and prognostications. And finally, I would like to thank you for your attention, and you are welcome for any question. Hello, Professor So, do you hear me? I cannot hear anything.
Oh, sorry. Yeah. I think you can, there is some question in the chat. So could you, I think you can.
Okay. There's a question, how do you suggest to manage prostate patients with PSMA PET-CT? Should positive few reps uptake with the normal CT, SUV max uptake 4.4 to 5. Actually, these days there is no consensus which is the the minimum SUV to identify this is pathological or physiological uptake. However, in quantification, they use COV3 as a standard, but it is not validated. And most of them recommend that when it is compared to the liver, COV uptake, but we should also consider the typical location for metastasis. For example, in ribs, we should consider for other causes in these patients unless approved. And I don't know what he means by few ribs. Few ribs, it can be less than 3. That's mean it can be also another benign. We should consider the pitfalls and births of PSMA as well. Maybe it can be a fracture or something else. But in normal CD, I assume there is no fracture. In this case, we need to confirm it or to be cautious about these patients. Is there a negative PSMA PET-CT detect recurrence? Will you suggest? Is there a negative PSMA? Would you suggest? Yeah, this question actually, fluorine PSMA detect recurrence. There is no difference, as I have shown in the literature. They compared which is better, either fluorine PSMA or gallium PSMA PET-CT. There is no difference in the performance of these radio tracers. There is no clear evidence which is better. They almost perform equally. And I don't have experience about this, and we didn't do it in our institute. We only do gallium PSMA, but there is no clear data that lesions which is not detected by fluorine 18 PSMA can be detected by gallium PSMA. However, if it is fluorine PSMA 1007, and there is which is known to show a high uptake in liver, maybe gallium PSMA is better. But it is the opposite in local recurrence. I hope it is clear to those who ask it. Any further question?
I have from your experience, what are some commonly seen false positive findings from the PSMA PET-CT?
Actually, we see the inflammatory reasons, for example, like mediastinal lymph nodes. We see also the fibrodysplasia affecting the bone. Also, we could see one time, for example, we could see the sarcoma uptake. For example, it show high uptake. We find one case, it has shown like showing mimicking prostate cancer recurrence, but when we check the history, it has a sarcoma 10 years ago, and this was biopsied and to prove it is a recurrence of sarcoma, not a recurrence of prostate cancer. These are the most common what we see in our daily practice.
Another one is that for the response evaluation, you have shown us a lot, some like studies ongoing for how we could use PSMA, but what is for the response evaluation for prostate cancer, PSA is the main, I think. But what is the adaptive or like what is the role of the PSMA imaging compared to the PSA, just using the serum PSA for the response evaluation?
Actually, these days, PSA used because the limitation of the other imaging modalities, because they cannot evaluate. RECIST criteria is limited. CT cannot evaluate the small lesions and cannot evaluate the sclerotic lesions in bone at the bone level. So a PSA used as biological biomarkers, but the problem, it cannot show where is what is the heterogeneity of response at the level, because we can see some lesions are responding, some lesions are not, where is the location of progression. And these findings might help sometimes to select what we call a metastatic directed therapy or focal or local therapy using the radiotherapy for those specific lesions. For example, in our example, in our study, this patient's B, he had only 2 lesions here in the rib place and in the femur. These 2 lesions has been treated with radiotherapy, and this, I think, it can be an additional value of the PSMA PET imaging. Another point, I think clinicians, they like to see what is happening really in the disease, and this PSMA imaging would show them what is going on exactly, while PSA is just showing the biomarkers at the blood level.
Like for imaging of dotatate for response, there was some arguments about the flare phenomenon after the lutetium therapy. Is there really some occasion for the PSMA imaging for response evaluation when you see the images?
There is a literature reporting a flare phenomena when we use the enzalutamide and abiraterone. I think we have some cases like this, but usually at 2 months. We find it at 2 months, but at 3 months and more, it is really to see something like this, but you can see at 3 months. But after that, for example, in this study, at the median of follow-up, at the median of follow-up of 3 months, there is no any flare phenomena because it was perfectly concordant with the PSA in this study. And like in taxane chemotherapy, we evaluated at the end of treatments. It was not at the interim stage. Also, we didn't find the PSA. We are expecting, because we are planning to do also an interim evaluation response assessment for taxane therapy. And we will see in the prospective trial if there is something like this.
Thank you.
Thank you.
Would there be any more questions or comments? Okay, I think there might be no more questions or comments. I really appreciate Dr. Qaid for your wonderful lecture. Thank you very much.
Thank you, and thank you for everyone.
Okay, thank you.
And have a nice day.
Oh, you too. Good morning. Okay, I think we can end the session today for now, and let's see you guys next week. Thank you very much.